Good afternoon. My name is Efren Santos. Welcome to today's webinar that is part of the Florida Caribbean AIDS Education and Training Center HIV Update Series. Today's session is entitled Non-Occupational Post-Exposure Prophylaxis Guidance. Today's speakers are Maribel Gonzalez, Saniyyah Mahmoudi, and Dr. Anna Alvarez. Today's speakers, Maribel Gonzalez is a clinical educator for the Florida Caribbean AETC. She has more than 15 years of healthcare experience, spending the last 10 years as an advanced registered nurse practitioner. Dedicated to public health, Ms. Gonzalez has worked as a community health nurse, educator, and researcher in public health settings. Most recently, Ms. Gonzalez served as the primary clinician for a rural Ryan White Part C clinic. She has developed and presented as a guest speaker at multiple AETC annual conferences. Saniyyah Mahmoudi is a coordinator and trainer for the AETC. She is an advanced registered nurse practitioner and director of education and CQI coordinator at the University of Florida Center for HIV, AIDS Research, Education, and Service, UFCARES, Jacksonville. Dr. Alvarez has been faculty of the Florida AIDS Education and Training Center since 2001. In 2005, she joined the Southeastern National TB Center as the pediatric consultant and as faculty of the comprehensive clinical TB course, giving quarterly lectures on pediatric TB. In 2013, she was appointed by the Secretary of Health and Human Services to the Advisory Council for the Elimination of TB of the CDC. She's currently an associate professor at the University of Florida College of Medicine, Jacksonville, in the Division of Pediatric Infectious Disease and Immunology. The activity planners and speakers do not have any financial relationships with entities to disclose.
Thank you, Efren. Thank you for the presentation. So today I'm going to start off with going over the session objectives for this webinar. Upon completion of this program, participants will be able to describe modes of HIV transmission in the pediatric population, differentiate exposures that require nPEP from exposures that do not require nPEP, describe components of care at initial office visits and follow-up exams. These components will include physical exam, mental health assessment, and labs. Participants will also be able to review a sample child protection team nPEP protocol. So let's begin the webinar by talking a little bit about some national statistics. According to the Rape, Abuse, and Incest National Network, there are about 293,000 victims of sexual assault every year. That means that about every 107 seconds, another person in America is sexually assaulted. Furthermore, there are about 68% of sexual assaults that go unreported. This means that only about 2% of rapists actually spend at least a day in either prison or jail. Let's go over some Florida statistics. Florida statistics are have a lot in common with the national statistics. They're very similar. Only about 18% of forcible rape is reported to law enforcement in the state of Florida. And when we're discussing rape in Florida, about 17% of women in Florida will be raped at least once in their lifetime. 79% of those women that are raped in Florida are under the age of 25 years old, and about 42% of those women are under the age of 18 years old. And there are also about 42% of women that are victims of other type of sexual violence that is not defined as rape. As far as men in Florida, about 27% of Florida men are 10 years old or less, and about 20% have been victims of other types of sexual violence. Moving on to going over some modes of transmission in the pediatric population. Those that are listed here, including breast milk, vaginal fluids, blood, semen, sexual contact, premastication, are all ways that HIV can be transmitted in the pediatric population. These body fluids must come into contact with a mucous membrane or damaged tissue or be directly injected into your bloodstream, such as by a needle or a syringe, for transmission to possibly occur. Mucous membranes are the soft, moist areas just inside the openings to your body, and they can be found in areas such as the rectum, the vagina, or the opening of the penis and the mouth. Some ways that HIV is not transmitted includes toilet seats, air or water. HIV is not transmitted by insects, including mosquitoes or ticks. HIV is not transmitted through water fountains. Casual contact, such as shaking hands, hugging, sharing dishes, drinking out of the same glass. Now let's go over some of the data that supports HIV post-exposure prophylaxis. Post-exposure prophylaxis is the use of antiretroviral drugs, or ARV, after a single high-risk event to stop HIV from making copies of itself and spreading through the body. Let's first talk a little bit about what happens in early HIV infection. Systemic infection does not appear to occur immediately. HIV usually initially affects target cells, and it takes time to cause a systemic infection. And the goal of prophylaxis is to attack the HIV virus prior to establishment of infection in the immunologically protected sites, such as lymph nodes or in the central nervous system. Currently, there are no randomized controlled studies that have been done to measure the efficacy of PEP in HIV. These types of studies would be unethical, and currently the only evidence that we have comes from animal models and the prevention of maternal fetal transmission in humans, and also worldwide retrospective case control studies. The first animal study that I would like to go over includes an animal study related to the macaque monkeys. And the macaque monkey, in this study, the macaque monkeys were exposed to simian immunodeficiency virus, or SIV, and then they were treated with tenofovir. And when we look here at the tabs, those monkeys that were treated for 28 days after exposure, they received 100% protection from SIV infection. Those monkeys that were treated for 10 days received 50% protection. And those that were treated for 3 days did not receive any protection from the SIV virus. This is the strongest rationale that we currently have for the 28-day treatment course for HIV PEP. In another study, a study that was looking at the timing of PEP, the macaque monkeys were inoculated with a SIV virus at a dose that usually results in infection. And in untreated macaques, they were followed by treatment with tenofovir. 100% of those treated within 24 hours remained uninfected. 50% of those treated within 48 hours were uninfected, and 25% who received their first dose at 72 hours were uninfected. Human studies of HIV and PEP efficacy. We have some experience with perinatal prophylaxis of HIV. In the ACTG 076 trial was a randomized prospective multicenter trial in which AZT was administered to HIV-infected pregnant women during pregnancy, labor, and delivery. And it was also administered to the newborn for 6 weeks after delivery. And we found that this reduced HIV transmission by 67%. In another retrospective case-controlled study where healthcare workers were evaluated, and it was controlled for other factors, other risk factors for HIV transmission. We found that about 81% that ZDV-PEP was associated with reduction in risk of HIV infection by approximately 81%. Dr. Alvarez is going to talk to us about non-occupational PEP.
Thank you, Maribel. So to start talking about this, the first thing we need to do is understand what exactly we're talking about when we say non-occupational exposures. So this means risk exposures following sexual and needle sharing activities, needle sticks outside of the occupational settings, trauma, including human bites. In this category, we also include sexual assaults, although they merit a special focus and, of course, should be handled in conjunction with a sexual assault team whenever that is possible. So what are the fluids and tissues that we get concerned when somebody's exposed to this? The first ones are the ones that we know have been documented to transmit HIV. And those include blood, visibly bloody body fluids, semen, vaginal secretions, and breast milk. Other potential infectious fluids, though not as well proven as the previous ones, but are highly potential, include other body fluids like CSF, synovial, pleural, peritoneal, pericardial, and amniotic fluid. The tissues and fluids that are really very low risk or no risk at all include feces, nasal secretion, saliva, sputum, sweat, tears, urine, vomitus, unless they contain blood. So if any of these are contaminated with blood, obviously that increases the risk. So in order to understand the basis for the recommendations for prophylaxis, it's important to have an idea of the estimated risks. So in this table, you see the estimated per act risk for acquisition of HIV from a known HIV-infected source per exposure route. The numbers are rated by 10,000 exposures. So as you can see, blood transfusion is the highest by far, 9,000. However, because in 1985 the program of donor blood screening started, this is not an issue anymore in the United States or in countries where blood donors, the blood is screened very carefully. So taking away the blood, then the next risks that are the highest include IV drug use, receptive anal sex, and needle sticks. So 67, 50, and 30% respectively there. Followed by receptive penile vaginal sex, insertive anal sex, and insertive penile vaginal sex, 10, 6.5, and 5. As you can see, receptive oral sex and insertive oral sex they do have a risk, but it's much lower than the other ones, 1 and 0.5. So we're going to jump and start looking at the management of an exposed or potentially exposed client. So the first thing that we need to do when we see somebody that has been potentially exposed is to evaluate the exposure risk. To do this, we classify the exposures into 3 categories: higher risks, lower risks, and no risks. So these are the higher risk exposures. And to clarify, we're talking about a source that is either known HIV infected or a source that with an unknown HIV status. So to clarify, if we know, if by any chance we have a source that has a recent HIV test and we know that the person is HIV negative, none of these applies. So it only applies to HIV infected or HIV unknown sources. So the high-risk exposures include receptive and insertive vaginal or anal intercourse, needle sharing, and injuries with exposures to blood or other potentially infectious materials. So these include needle stick with hollow bore needles, human bites, and accidents. The next category is what we call the lower risk exposures, and these include oral vaginal contact, oral anal contact, and receptive or insertive penile oral contact with or without ejaculation. In these cases, there are some factors that increase the risk and then they need to be considered. And that includes if the source is known that is HIV infected with a high viral load, of course that increases the risk. If there is the presence of non-intact oral mucosa, like a person has oral lesions, gingivitis, or wounds in the mouth, any blood exposures during these activities, or the patient also, or either one has genital ulcers or any other sexually transmitted infection. So obviously these increase the risk and will make these activities higher risk instead of lower risk, or at least medium risk. The ones that are considered no risk, that obviously do not warrant post-exposure prophylaxis, include kissing. And in here, it's important to differentiate closed-mouth kissing, which it basically represents no risk at all, versus the open-mouth kissing might have some risk, some remote risk, if there is bleeding or there's sores in the mouth while this is going on. Other no-risk categories include oral-to-oral contact without mucosal damage, as is the case of when somebody gives mouth-to-mouth resuscitation without any mucosal damage. Human bites that do not involve blood. Exposure to solid bore needles. So these examples of these needles would be the needles used for tattooing, or sharps. For example, the sharps that, the lancets that are used for testing glucose, for example, among diabetics. If they have no recent contact with blood, then they're considered basically no risk. And the last one is mutual masturbation without skin breakdown or blood exposure. So once you have established the category of the risk, the next step is to consider the time that has elapsed from the exposure to the time you're evaluating the person that has been exposed. This is important because there is a time frame within which post-exposure prophylaxis is efficacious. And it's important to start these as soon as possible. So the simplest rule to remember is the sooner, the better. However, we do have to establish some cutoffs for times. The DHHS guidelines from 2005 uses 72 hours as the critical time to start post-exposure prophylaxis. However, more recent data suggests that 36 hours is better and it's more efficacious than 72 hours. So this is the time that now most of us are recommending, meaning that that's the time within which it's if PEP is recommended, it should be started. So going back to these table that is borrowed from the New York State guidelines, they use 36 hours as the cutoff. So once you divide the risk into higher, lower, or no risk, you go through the time. So if you have a higher risk exposure and the person presents less than 36 hours post-exposure, definitely PEP is recommended. If the person you're evaluating presents to you more than 36 hours post-exposure, then a case-by-case evaluation is recommended. In general, if the person presents between 36 and 72 hours, most experts would still recommend to start PEP if they have high-risk exposures. If it's beyond 72 hours, because we have no evidence that there's any efficacy for that, it's probably too late to start prophylaxis. Once you have a lower risk exposure, the next step is to evaluate if there's any presence of the additional risk factors that would change the lower risk to a medium risk category. If there are any of those factors, then those cases should also be evaluated case by case, and many of them are gone and start prophylaxis. If there are none of the factors that increase the risk and the exposure is considered lower risk, or if it's considered no risk exposure, then no prophylaxis is recommended. So the timing of the post-exposure prophylaxis is really extremely important. The recommendation, as I said before, the key thing to remember is as soon as possible. Ideally, should be started within 2 hours of exposure. So this is very, very hard to do because in many places where patients that have exposed get evaluated, more time has occurred. And also, they don't have the availability to obtain the drugs that quickly. So it's really a consideration to actually start what we call a 3-day starter packs available in places where people in crisis present. So ER, urgent care facilities, and other areas where persons with exposure present for care. That way, it gives enough time for the person to start the prophylaxis. We at least 3 days to start, and gives time to then obtain the rest of the medications that are needed to complete the prophylaxis. As I said before, there is very little evidence to suggest that there is any efficacy if this is started after 72 hours post-exposure. Once we start prophylaxis, it is recommended to treat for 28 days. So what are the preferred regimens for prophylaxis? And this has changed several times throughout the years, but this is the most current recommendation. So for adults or post-pubertal adolescents, the recommendation is to do a combination of one pill that contains tenofovir and entrectinib. It's called Truvada, 1 tablet daily, plus either raltegravir or dolutegravir. These are integrase inhibitors, which is one of the newer classes of antiretrovirals, but are better tolerated and very efficacious. Raltegravir is twice a day, so that's a disadvantage, but it's more readily available, it's easier to get, and it's cheaper. Dolutegravir TVK is only once a day, but as I said, sometimes it's a little bit harder to obtain. So, but they are both very, very effective. In the next slides, I've included several tables that have the doses of these antiretrovirals in pediatrics. So dolutegravir is not available for pediatrics. We don't have any pediatric formulation for that. However, raltegravir is, and it is approved actually for babies 4 years of age or older that weigh more than 3 kilos. So we actually have are able to use this in exposed babies when they're in the neonatal period. It comes in chewable tablets or in oral suspension, and in the table there you have the different doses according to the weight. Obviously, for kids, because we have to dose the medications per weight and the different dosing, there is not a combination of tenofovir and entrectinib, so they have to be given separated. So the tenofovir comes in a powder or a tablet, and you have there in the table the doses according to the different weights. And then for entrectinib, it's an oral solution or the adult size, the tablet for adults. These medications, tenofovir and entrectinib, are approved for 2 years old and older, but they haven't been approved for babies yet. So other regimens that can be used for post-exposure prophylaxis include darunavir boosted with ritonavir or atazanavir boosted with ritonavir. These are PIs with boosted with ritonavir, plus one or the other, plus 2 NRTIs. So it could be a combination of tenofovir and entrectinib as Truvada, or tenofovir lamivudine, or even cytidine with lamivudine when there is a contraindication for tenofovir. So these are an acceptable regimen. Another alternative regimen are the pills that are combined into one pill. So you have elvitegravir, cobicistate, tenofovir, and tricitabine, which is called Strivil, and has 4 drugs into one pill, and it's taken once a day. Or you have Complera, which is rilpivirine, tenofovir, and tricitabine, that also is 3 drugs combined into one pill, taken once a day. Because there is less experience with these for post-exposure prophylaxis, also the cost is higher. They're not first line, but they are acceptable regimens if the other ones are not, can be used, or if they are available. Now, once you decide that that a person has a significant exposure, then the next thing to do is to do some testing on the exposed person. It's recommended that the person gets a baseline HIV test within 3 days of exposure. And this is not to identify that the HIV is acquired through the exposure, but just to separate the person that is already infected from somebody that is not infected. It is important because if somebody is already infected, there is no point in doing prophylaxis. That person needs treatment and should be referred for treatment, but doesn't need prophylaxis. So it's important to know the status of the person that is exposed. For women, it's important to do pregnancy tests, and based on the site of exposure, GC and chlamydia testing, as well as RPR. Now, if the exposed person declines HIV test, the person definitely does not want to be tested for HIV, we have to accept their decision. But in that case, we do not offer or continue the post-exposure prophylaxis. In cases of sexual assault, obviously the considerations for STI testing and pregnancy and the consultation with the sexual assault team become extremely important. Now, if the source is available, known or available, then the ideal thing would be to obtain consent for HIV and test that person with a rapid test. Now, we do not delay, if the decision is made based on the risk, basically, if there's a higher risk exposure, we do not delay the start of the prophylaxis awaiting the results of the HIV test on the source. So that the focus should never be the HIV test of the source, but more the type of exposure. But if that person is available, the source person is available, and they accept to get an HIV screening, if that screening is negative, then we need to ask about potential exposures and risk factors, meaning a person that have been exposed to, possibly exposed to HIV within the prior 6 weeks. And in that case, it's recommended to continue the prophylaxis on the exposed person, but obtain HIV RNA assay on the source person to really make sure that that person is not in that window period of conversion. And then if that is the case, then we continue the post-exposure prophylaxis on the exposed person until we have the results of the HIV RNA on the source. So again, the focus should never be the HIV status of the source. The focus of the initial evaluation should be the exposure, determining if it's a high-risk exposure or not. Now, if the source is unavailable, or if the source refuses HIV test and we are dealing with a high exposure, then obviously the PEP is indicated and it should be started soon and continue for 28 days. In the case that there is a source that is known and it's known to have HIV, then obviously it's recommended to start immediately the PEP regimen. But it's important to try, if possible, to get information on the source case regarding viral load and a possible resistance, so that the regimen, the PEP regimen, may be changed based on the resistant pattern of the source, if that is available. But that can be done days after, so we should never delay the start of the PEP, awaiting all of these other results. But it's important, if we have that available, to evaluate those, because we might have the need to change the regimen. So once we decide that a person has a significant exposure, a high-risk exposure, the person is going to need to be tested several times for HIV. So the first test would be done at the beginning, so within 3 days of exposure. That would be the baseline test. And then we do repeat the HIV test 6 weeks, 12 weeks, and 6 months later, if the test that is being used is not a fourth generation test. And I'll talk a little bit more about that in the next slide. Now, if the test that is being used is a fourth generation antigen antibody test, then the HIV test should be done at baseline, 6 weeks, and 4 months. There are places like New York where they do use the fourth generation test always, and they test at baseline, 4 weeks and 12 weeks, and then that's it. Now, if the exposure was considered high risk and PEP was recommended, but the patient declined, the exposed person declines using the post-exposure prophylaxis, it should be clarified to them that the follow-up test should still be done at the same time. So even if this test should be done if the person takes prophylaxis or doesn't take prophylaxis, but if the situation, the high risk is basically the prophylaxis is indicated based on the risk, then this test should be done. So this is important. It's important to remember that the conventional HIV test tests for the presence of antibodies for HIV. But remember that there is a window period where a person can actually be infected with HIV, but is not hasn't developed antibodies yet. That's called a window period, and so it's important to understand the window of detection of the different tests. And so this table is this graph here is to explain that a little bit. So let me see if I can explain it to you, make it a little bit clear. So the horizontal line is, if I can get this here. Okay, so this horizontal line is the time since infection in days. So it goes from 0 to 100 days. Then you see you have this here. It represents the HIV RNA in plasma, which becomes detectable in about 10 days after the person gets infected. So let's say a person gets exposed and is infected. It takes about 10 days for the RNA to be detected in plasma. The second curve here is the HIV P24 antigen. And that starts to become detectable in blood at around 17 days after day 0 here. Then you, at about 22 days, depending on the generation of the test that we use, the HIV antibody becomes detectable, and then it's detectable for the rest of the time. The P24 antigen disappears around 45 days or so. And the RNA increases initially, but then decreases to establish a set point. However, it is detectable during all this time. So on the bottom here, you have the different generations of antibody testing, of testing for HIV. And so you can see that as we get better with these tests, going from first generation to second generation to third generation, the time to detection, so that window period from the time the person is infected to the time that is detected, gets shortened. But the best test really that will detect the earliest the infection is the nucleic acid amplification or the HIV viral load, the RNA, because that can detect the infection as early as 10 days after infection. However, the difference between the third and the fourth generations are significantly better, and in many places that's what is used in these cases. Difference between third generation and fourth generation is that the fourth generation test not only tests for the antibody, but it also tests for the P24 antigen, and that allows the detection to be about a week sooner than the third generation test. So obviously, there is an advantage to the fourth generation test. My last slide is really it's a little bit complicated table, but it's basically a summary of the recommendations for evaluation, laboratory evaluation of a person that is exposed, and it also includes evaluation of the source. So you see that at baseline, the exposed person should have an HIV test, should also have baseline test of, especially if obviously these tests are done if the exposure is considered significant to recommend PEP, PEP. So basically we do baseline CBC, liver function, and renal function. And then we also do recommend, depending on what kind of exposure it is, sexually transmitted infections, so GC, chlamydia, syphilis. We also recommend baseline hepatitis B serology, hepatitis C serology, pregnancy test. For the source, also is recommended HIV, the sexually transmitted infections, and also the hepatitis. If the source is known to have HIV, then it's recommended to do viral load, CD4 count, and resistant testing if that's not available. So then the person starts the prophylaxis. In around 2 weeks after starting prophylaxis, it's recommended to repeat the safety labs. These are just to detect potential adverse events or related to the medications. So we repeat the CBC, the liver function, and the BUN and creatinine at around 2 weeks. Depending on what the risk for the other sexually transmitted infections that can be repeated at 2 weeks too, it's the same thing as the pregnancy test if the woman is in reproductive age. Then at 4 weeks, we repeat the HIV test, the sexually transmitted infections, the hepatitis B serology can be repeated at 4 weeks, and the pregnancy test. If the exposed person tests positive at that time, then obviously we do further evaluation for the HIV infection, so viral load, genotype, and so on, CD4 count. At around 12 weeks after the exposure is the last HIV test if you're using a fourth generation test. And then at that time we also do the final hepatitis B serology, and then a repeat hepatitis C serology. And then at 6 months, we do the last hepatitis C serology. But I think Saniyyah is going to go in further detail about the management of hepatitis B and hepatitis C exposures. But basically, in this table, it summarized the evaluation of the person that in which PEP is recommended. Saniyyah?
Yes, thank you, Dr. Alvarez. So this slide, I just wanted to mention to you that the website cdc.gov has this sexually transmitted diseases guidelines from 2015, and I found these guidelines really beneficial. It talks about all STDs, GC, chlamydia, trach, as well as syphilis. When do you test? For instance, GC, chlamydia, and trach, you treat empirically with antibiotics at the time of the assault, if there's sexual assault. It also gives you information about Hep B and Hep C that I'll be mentioning next, as well as HPV vaccines that need to be given to the person that's exposed. So just to talk a little bit about hepatitis B, I found this very, very helpful. At the time of the assault, it's really important to check Hep B surface antigen, Hep B surface antibody, and Hep B core antibody total on the person that's exposed. If talking to the person that's exposed, you find out that they have been unvaccinated or they did not complete their vaccination series, then the recommendation is to give to this person Hep B immunoglobulin, and this is at 0.06 ml per kilo IM times 1, and start vaccination. This could be done in the clinic that's following the patient, does not have to be the day of the assault. It can be given within the first 14 days after the incident. If the patient, you found that they have been vaccinated and their hepatitis B surface antibody is positive, it means they're immune, then there's no need to give the immunoglobulins. If the exposed person has been vaccinated but their Hep B surface antibody is negative still, so they don't have immunity, then if they had received the first series of the Hep B vaccines only, then you give him immunoglobulin times 1 and you vaccinate the patient. If the patient has received the series twice and they're still negative, then the recommendation is to give the Hep B immunoglobulin twice at the time of exposure and 1 month after. And if this patient has been vaccinated but we don't have any Hep B surface antibody response results, lab results, then the recommendation is to test them and then follow the algorithm as above. So how about Hep C? And people, patients who've been sexually assaulted or any blood contact, they are at risk for Hep B and Hep C infection. If there is for Hep C consideration, if you are unable to obtain the Hep C status of the source person, the perpetrator, then the recommendation is to test the person who has been exposed, the victim, test the anti-ACV, and do a liver enzymes, ALT, for the exposed person. And then repeat that at 4 to 6 months. Or if you're doing a PCR, then you can repeat that at 4 to 6 weeks. There is no post-exposure prophylaxis for Hep C, unfortunately, but just testing and make sure that they don't become serologically positive. But there's treatment if they become positive, but that's not what we want. We want prevention, I hope. So follow-up education for the person who is exposed to STDs and HIV and they've been assaulted or they're exposed. Provide health education to the patient and the family, stress medication adherence once you start the ARVs, and also stress risk reduction, provide risk reduction counseling, and I'll mention that again in the future, in the next slide. Provide emotional support and psychological counseling for the patient and the family, and provide education on signs and symptoms of acute HIV infection and the need for urgent visit to the provider. So if the patient is on a prophylaxis or if they refuse prophylaxis, it's important to tell them what are the signs and symptoms of acute HIV infection. And basically, the signs and symptoms could be just like a flu-like illness. They're having maybe fever, sore throat, pharyngitis, myalgias, and there are other signs, but they're usually the top kind of signs and symptoms are the flu-like illness that happens. But patients who are infected could have malaise, headaches, neuropathies, lymphadenopathies, rashes, GI symptoms, spleen and liver enlargements, and sore and thrush. So counseling of the client, they need to have a good understanding about the benefits of nPEP and as well as the risk of side effects of nPEP. Understand the risk of infection if they get HIV infection and what can happen, or any other of the STDs that we are mentioning. Adherence, trust adherence, using precaution to avoid transmission in the first 6 to 12 weeks after exposure. That means that they need to be using condoms. If they're having sexual intercourse, they need to avoid pregnancy, breastfeeding, tissue and blood donation, and manage symptoms and side effects. And I have some tables here about side effects of the ARVs. And the most common side effects of all the ARVs that we're going to use in nPEP are malaise and GI disturbances, nausea, vomiting, and diarrhea. However, I'm going to go through some of the signs and symptoms. Just I want you to remember that the treatment is only for 28 days only, and some of the chronic damages or increased signs and symptoms does not happen within the first 28 days, but it can. Nothing is 100% sure. So lamivudine that we mentioned, it's in the NRTI class, which is nucleoside reverse transcriptase inhibitors. It's lamivudine, the signs and symptoms, fatigue, GI disturbances, and headache. Emtricitabine is fatigue, GI disturbances, hyperpigmentation of palms and soles, and that is increased risk in black and Hispanics versus whites. Tenofovir is nucleotide reverse transcriptase inhibitor, and the signs and symptoms, GI disturbances, headache, and renal insufficiency. And actually, some renal acute renal injuries can happen with tenofovir, and but like the nPEP is only for 28 days, so hopefully that is not going to happen within that short period of time. Zidovudine is GI disturbances, headache, and anemia. And unfortunately, I have seen anemia occur very fast with people who are on zidovudine. Within 1 or 2 weeks, they can become anemic. Dolutegravir they are integrase inhibitors. It's headache, insomnia, and hypersensitivity reaction, and raltegravir is another integrase inhibitor. It's GI disturbances, headache, pyrexia, and hypersensitivity reaction. For the protease inhibitors, atazanavir can cause increased unconjugated bilirubin, and that in turn will cause some jaundice and scleral icterus. And if that happens, the patient is not really having hepatitis or liver damage, it's because of the atazanavir. It can also cause prolonged PR interval nephrolysis and cholestasis, but this is for long-term use mostly, and not for short-term use. Darunavir, rash, GI disturbances, headache, hepatotoxicity, and with the Darunavir you have to use caution if somebody has sulfa allergy, but it's not contraindicated, you can still use it. Ritonavir is only used as a booster for the darunavir and the atazanavir. It's in a very small dose, but it can still cause some dyspepsia, GI disturbances, and lipid elevations. So I wanted to go over we're trying to work on the protocol for the child protection team, and this is from the protocol, and it's not set in stone, but I thought that some of the information is, helpful to be included. So when you are evaluating the circumstances of sexual assault at the child protection team, you are trying to determine the infection status of the assailant, duration of the assault, is it once or repeated assault, the level of trauma, type of penetration, and of course you are determining from the table the risk factor for the victim. So you're using the algorithm to prescribe nPEP, and it should be started, nPEP should be started as soon as possible. And New York guidelines that they have set up there, they prefer 36. CDC says less than 72 hours. So after 72 hours, there's no recommendation for nPEP unless the patient really wants it, and the parent really wants it, and they don't care, and then you need to consult with a specialist. But the recommendation is as soon as possible, within 1 hour, 2 hours, as soon as possible, and it should be within 36 to 72 hours of exposure. There is a national hotline that you can call and ask questions, and the child protection team, or ask the HIV specialist in your area. Prescribing medications is important, and it can be done at the child protection team. That's recommended. I highly recommend it. Provide instructions on the medications, potential side effects, call the pharmacy, make sure that they have the medications. However, if the patient does not have insurance, then there are patient-assisted programs at the different pharmaceutical companies, and they are easy to use. So I call in the number and I say I need post-exposure prophylaxis for my patient. And they say, okay, what's the name, what's the date of birth, what's the address, what's their phone number, and they give me an authorization right then that I can take to any pharmacy and the patient can get the medication. This is one company that I have dealt with. But as you, Dr. Alvarez mentioned, the nPEP is more than one drug. The emtricitabine tenofovir comes as Truvada, that's one company. But then the raltegravir or the dolutegravir are two different other companies. And I'm trying to put the information in the updated CPT protocol for CPT personnel to be able to access. There's a questionnaire. It's a plus if it's done, and you can share information with the HIV specialist. And then at the clinic where the patient is going to be seen, there's going to be clinical evaluation, risk of go over with the patient the risk of HIV transmission, any concerns from PEP, if they're having any side effects. If the drug has not been started, the nPEP, then go ahead and start it. And then HIV testing to be scheduled again for 6 weeks and 3 months and then 6 months after the exposure. Lab tests to be done, as Dr. Alvarez mentioned in that table, but this is a summary. HIV ARNP-PCR test, CBC if prescribing nPEP, chemistry, serology testing, and STD screening as needed if they were not done. And then follow the algorithm and try and, give it for 28 days. It should be started as soon as possible, the nPEP. And these are a couple of cases that we can go over. 15-year-old male sexually assaulted in the morning by a 48-year-old male known to be HIV and Hep B co-infected. So the patient was evaluated by the child protection team and was referred to our clinic. And so testing was done on the patient, and we started the patient. They had insurance. We started them on Truvada and dolutegravir because both of them are once a day pills, and the patient was okay with that. The patient was more than 12 years of age, so we could give him dolutegravir. And then we found that the patient was suicidal, so he was Baker acted. And I see our time is going down. I don't know if we should open it for questions. exposure prophylaxis, brochures that were developed by the Florida Caribbean AETC, and they're available online. Clinical consultation number is important. Our resources, our major resource here is Dr. Beal in Florida, and that's his email address and phone number. We thank Dr. Janelle for some of the slides that we pulled from her presentations to use today, and questions and answers.
Okay, there's several questions. The first one is, I have worked as a nurse examiner collecting forensic evidence on rape victims in a health department-sponsored PRN position. There was no option for providing nPEP in that environment. How could this be provided to individuals without a payer source, insurance coverage? Is there a patient assist for this form of pharmaceutical companies that you are aware of?
I can answer that, and I think I answered it in my presentation also. If the patient doesn't have insurance, there are patient assistance programs. All the companies have them. It's just you have to call them and get authorization. They give you an authorization number, and the patient can go to the pharmacy and get the medicine. The only caveat is that the patient cannot have Medicaid. So if they have Medicaid, they cannot get it.
Question number 2. Define pre-mastication for the entire audience.
I can do that also. It's when mothers chew their food and feed it to their babies. And there have been incidences of HIV transmission to babies because of that. Because when the mother is chewing, if there's any blood or any type of body fluid that the baby can get.
Question number 3. Are there any studies on efficacy of prophylaxis for sexual assault victims specifically?
I can answer that. There's actually no data specifically in that population. However, there is no reason physiologically and pathophysiologically to believe that it wouldn't work, just like it works for in other settings of exposures. So basically what we know from other exposures, it's applicable to sexual assault exposures.
For the previous question in regards to the coverage of insurance, there was a comment made saying that Medicaid does have payment for nPEP as well as PrEP. There is a form to complete under prior approval section of Medicaid website. And another question that we had was, can we stress that the guidelines supporting starting if less than 32, with New York guidance setting 36 hours?
I can answer that too. So basically the Department of Health and Human Services guidelines, which are basically the body that governs us, their guidelines still say 72 hours. So basically if a patient shows up and can start PP within 72 hours and the risk is considered significant, so high risk, then it should be started. I think the stress is that we shouldn't feel too comfortable with the 72 if it can be started sooner than 36 is better. So that's why I say the key thing to remember is the sooner the better. So but within 72 hours is perfectly acceptable within the DHHS guidelines. Now, after 72 hours, there is really no data that of the efficacy. However, if a person, either the person that has been exposed or the parents of a child that has been exposed in different categories are they really are interested in getting prophylaxis, then we should offer it. I think that declining that, we really don't have any data to say that it won't work either, but we just don't have data to support that it will work. So it's in that case, it's really a big discussion about risk and benefits of doing, giving drugs that could potentially have side effects, and we don't know if they actually have any benefit at that time after 72 hours. But we never say no to people that feel strongly about getting on prophylaxis, even if it's, close after 72 hours.
Then I made just a clarification on the patient assistance program. When we call drug companies, they ask if the patient has any federal funding or Medicaid or Medicare, and they do not provide PEP if they do. But if the patient has Medicare and Medicaid, then they can get their medications. That's what I meant. So sorry, Dr. Beal. I meant if they do have Medicaid, they can get their medication from the pharmacy. But the pharmaceutical company provides patient assistance if they do not have Medicaid and Medicare.